Good afternoon and good evening, depending on where you may be. Thank you so much for taking time. It is my pleasure to welcome you to Cornell Silicon Valley's Telehealth Takes Off, an event brought to you by the Cornell West Coast Alumni Affairs team. In these challenging times when there's so much uncertainty in the world, we so appreciate you being with us today. My name is Charles Wu, and I'm a member of the Cornell class of 1991, and it's an honor to be collaborating with the West Coast team on today's event as they serve the Cornell community by enhancing and building connections among alumni, parents, and friends from Seattle to San Diego. Our panel is so pleased to be sharing this time with you as well. Before we start, I'd like to take a moment to recognize the passing of alumna Supreme Court Justice Ruth Bader Ginsburg, a jurisprudence giant who always represented Cornell with great honor. We, along with others, pay our respects. In addition, in this time, it's also great to hear, if you have not seen this wonderful story on Good Morning America about how Cornell is managing the pandemic through an innovative testing and tracing strategy. If you haven't seen the story already, it's worth your time to check it out. Before we start, I'd like to offer a few housekeeping tips for today's event. While you are all muted, our panelists would still love to answer your questions. So please use the Q&A feature of Zoom at the bottom of your screen to type in questions. We'll get to as many as possible. At this time, I'd like to invite our panelists to turn on their video so I may introduce them to you. The coronavirus pandemic has required healthcare to change the rules of care and adapt. And it is my pleasure today that we have some rule breakers to explain where we are going now with telehealth and where the potential is. It's my pleasure to introduce them to you. I'll add that we've asked all the panelists to share what class or experience at Cornell most inspired them. First on our panel is Jamie Edwards, class of 1996 and MBA 03. He's the CEO and co-founder of Cloudbreak Health. Jamie noted that this is an easy one to answer because it was Professor Ben Daniels' entrepreneurship and personal enterprise class. It was so influential, he took it twice, in fact, once as an undergrad and once as a grad student. Professor Ben Daniels introduced Jamie to the notion that entrepreneurship was more about than just financial statements, marketing, or access to capital. At its core, it was the ability to take an idea in your head, make it real, and have it positively impact as many people as possible. It has been the guiding principle to Jamie's career since graduation. Next on our panel, we have Christine Sue Evans, Chief Marketing Officer over at Ginger. Christine was a textiles and apparel major, now known as the Fiber Science and Design program in the College of Human Ecology. Some of her best memories took place in the design studio with her classmates, where they would work on projects for hours on end, late into the night. Some of them even incurred some sewing and other production-related injuries. There was something so magical about that shared experience of solving problems together and alongside one another in a way that required equal parts intellectual power and raw technical skill. Even now, in her second career and her fourth venture-funded company, Christine is drawn to environments where creativity, failing fast, and camaraderie are keys to success. Next up is Sharam Golami, class of 1992, who is the co-founder and chairman of VMDoc, in addition to being a practicing physician. Sharam noted that access to faculty at Cornell opened many doors in his pursuit of his medical career. The ease of collaboration with faculty and the many opportunities for research paved the way for academic and intellectual exploration. This personal mentorship by the world's leading scientists and thought leaders has allowed him to materialize his own academic curiosity into tangible research, medical innovation, and business opportunities. And we conclude the panel with Felicity Yost, class of 2012, who's the co-founder of TIA. Felicity shared that having the opportunity to dive deep into topics that made you think and that you were interested to learn more about just because you could. For her, this was represented by Professor Kaplan and Laurent Ferry's class on Versailles and the Abîme. After Cornell, what she's most thankful for is that she can go to pretty much any city and connect with Cornellians in her class. As for me, what meant to me was my freshman writing seminar. Started at the very beginning, and Professor Dan McCall's relentless expectations forced me to improve my writing to the point where, as an engineer, I started to enjoy writing and eventually wrote a column for the Cornell Daily Sun. Well, thank you so much. As you can see, we have a full range of presentations and perspectives from the patient perspective, the provider perspective, the platform provider, and of course the payers. So I'd like to take this moment to ask each participant to turn on their screens and turn on their microphones, and then they will share a bit about their current role, how they got there, and we'll start off with Jamie.
Thanks, Charles. Jamie Edwards, I'm the CEO and co-founder of Cloudbreak Health. Really excited after spending 6 years in Ithaca to now be on a webinar with so many esteemed alum to talk about telemedicine, which is clearly a rapidly growing and burgeoning sector. Cloudbreak Health is a healthcare disparity solutions business. We started off bringing language interpreters to the point of care for limited English proficient and deaf and hard of hearing patients, and over time expanded the platform to do more. We realized that with 10,000 video endpoints in the field at 1,500 hospitals performing over 85,000 encounters a month, that we had the ability to not just bring interpreters to the point of care, but specialists, case managers, nurses, whatever it might be. And in 2016, we won a Patrick Soon-Chung Innovation Award for really bringing unified telemedicine to market. I think we're at a really interesting point right now in the history of telemedicine. I mean, telemedicine has actually been around for 20 or 30 years, but clearly COVID has been a huge catalyst when it's come to telemedicine's adoption and the creation of what we're all calling now the new digital front door. Our goal as a company is to make sure that telemedicine is simply the new medicine, and that what we're really witnessing right now is the digital transformation of healthcare on a broad scale. It's like finally, healthcare is catching up to other industries in terms of integrating digital health tools into the care continuum. And what it's really done, and we're a startup health company as well, which is a pretty big healthcare tech accelerator, the leading one. And our main moonshot that we're going after with Startup Health is how do we increase access to high quality healthcare with devices that people already have and are carrying around with them on their hip. I mean, we now have supercomputers that we're walking around with, which, you know, many years ago just simply weren't available. So very excited to be here with everyone today on a day where, you know, companies like GoodRx went public to quite a lot of fanfare, where American Well is now public. We're really seeing digital health become mainstream. And one of the things that we constantly talk about in healthcare, interestingly enough, is that the issues that face healthcare really aren't technology problems. They're issues with culture, they're issues with design, and how do we change human behavior. And so we spend a lot of time as a company really focused on how to create platforms that are easy to use, that bring care teams together around a patient in a really functional way. So keeping it simple from a design plan, from a design standpoint, thinking about platform instead of point solution, and really enabling the local continuum of care with telemedicine, not necessarily creating a new care model, but really saying, look, there's an acuity funnel. And as we move up that acuity funnel, it starts with the digital front door. You get directed to your place of care, and then eventually that ends up being in the ultimate, you know, in-person visit. So for us, telemedicine is this canary in the coal mine for what is the larger digital health transformation. And you know, when a doctor approaches you with a stethoscope, we don't talk about him practicing stethoscope medicine. We're really looking forward to that just simply being what we call the new medicine. With that, Christine, take it away. I'll hand it off to you.
Perfect. Thanks for that. Hi, I'm Christine Evans. I'm the Chief Marketing Officer at Ginger. I have been in the digital health industry now for the last 10 years, as Charles noted, in my second career, the first of which made direct use of my degree from Cornell and made this sort of interesting evolution into the world of health tech and healthcare marketing. So previous to Ginger, I was at Fitbit, which you guys might be familiar with, Castlight Health, another company in the Bay Area, and have been with Ginger for the last 2.5 years of their thus 10-year journey so far. So Ginger, for those of you who aren't familiar, is an on-demand mental health company, and our vision is to work towards a world where mental health is never an obstacle. If you have yourself or someone you know have ever tried to look for mental health support or help, it's pretty hard to do. very difficult to access the care that you need it, incredibly expensive for folks because most providers actually don't practice within a network and don't accept insurance. And in fact, I think 50% of counties within the US actually don't have a mental health professional within county lines. So huge issue here. Stigma, obviously something that I think we've come to terms with culturally, not just here in the US, but around the world. As a result, I think a lot of people who maybe previously didn't think that they needed care are now coming online and looking for that. And that's a problem that we need to solve for. And certainly I think for some of our largest payers in the country, including employers, this is an enormous problem for them, right? They're paying for benefits that aren't delivering. There's an impact on productivity, well-being of their employees, and in many cases, health outcomes and healthcare costs, right? Mental health issues are like depression and anxiety are comorbid with a number of chronic conditions. That's been very well documented. And so this is where we come in. You know, we're an entirely new delivery model, all done through the phone. And we do things differently in kind of two ways. One, everything again through the smartphone, coaching, right, which is that first layer of care. Within 60 seconds, you can be connected within a coach that you can text back and forth with anytime, 24/7, 365 days a year. If needed, and as you build that relationship with a coach, you will be able to have access to a therapist or psychiatrist through Ginger, through video, if you need that level of care. So really, I think some innovation in terms of how we're saving some of the I call it the dearth of resources. We think of ourselves almost, I won't say first and foremost, but much of our focus is on supply and demand of providers and the shortage of mental health providers that we have out there. When we have coaches who are skilled, who are trained, who can help people with really, 80 to 90% of what they're managing, we can actually reserve some of those resources for those times when people need the escalated level of help through a therapist or a psychiatrist, and they can do that all collaboratively. So some of our clients, we work with about 200 plus companies around the world. Millions of people actually have access to Ginger across 30 countries. Sephora, Delta Airlines, SurveyMonkey, Domino's, some of our clients who provide Ginger as a benefit to their employees. So I would say we're so glad and thankful as a company that we can be here, I think, for this moment in time in particular, and all of the work that we've put in over the last decade at a time when people need it most. There's no better reward than to be ready for this. So nice to be here with all of you. And I'm going to pass it over to Sharam.
Thanks so much, Christine. So I've been in the healthcare tech space for the past 15 years, and over the past 4 or 5 years, we developed a company called VMDoc, and it was really being a practicing clinician. It was our answer to figure out how to mend this deteriorating relationship between the doctor and the patient. Historically, you went to the doctor, you had an intimate relationship with them, you can call them, drop in, they would follow up with you, they would even come to your house and visit you. And that sort of relationship has gone, and modern medicine today is really episodic and reactive. So you have a problem, we fix the problem. You have high blood pressure, we give you a pill. And 3 months later, you'll come back and we hope that it worked out. And that whole foundation of healthcare, which is centered around this electronic health record, has unfortunately, fallen short in providing patients the real end-to-end care that we used to provide as physicians, I think. And what VMDoc has done is it's created this goal of simplifying the healthcare experience and incorporating modern technology into what everybody else does in terms of reaching out to their customers. We as physicians have to start thinking about our patients as customers and try to reach out to them and connect to them from the beginning to the end of medicine, if you will. We do this by solving 3 major problems in healthcare that we think are at the root of this. One of them is workflow automation. We think that for physicians and patients, there's a lot of paperwork, if you will, that goes back and forth in terms of re-entering and entering information. And each system decides to keep your information, and really there's not a lot of interoperability that goes on, which is the second issue that we work at VMDoc, which is modernizing that health data gathering, sharing, and interoperability. So it doesn't matter where you see a clinician. It could be someone online in telehealth. It could be someone at a clinic, across the country, or it could be your local doctor. But being able to have real modern data that actually that can transcend these healthcare EHRs, I think is important. And finally, we make the health record the patient's real personal health passport. And so the VMDoc Health Passport is an important part of it, because truly your health record is your health record. And it should be complete with everything that you do. And in order to do that, you need a place centrally where things are kept, and they can not only follow the medications and doctor's visits that you have, but also there's a lot of technology now in terms of how do we monitor patients for blood pressure, for blood sugar, for a variety of things at home. And really, we don't bring that information that we have back to the doctor in a really succinct and convenient way. So VMDoc's ultimate goal is to provide this data-driven system that's more predictive, prescriptive, and personalized to each patient, as opposed to being reactive. And we use this real-time data that's gathered from the health records, it's gathered from their treatments of doctors, and it's gathered from the collection of data recorded outside the physician's office. So in essence, we can bring the doctor home with you for our patients. And by doing this, we provide this truly end-to-end virtual healthcare experience for patients. And I'm gonna pass the torch to Felicity to tell us about what she's doing.
Hi, I'm Felicity. It's really wonderful to be here with all of these extremely experienced healthcare professionals, and feel a bit like an imposter among them. And part of that is because actually my journey in the healthcare space is relatively new compared to some of our other folks on the panel. But I'll give you a little bit of a background into how I came into being the co-founder of TIA, and hopefully that can start to kind of lay the groundwork for some of the discussion that we'll be having here today. So I actually didn't start out as a healthcare professional, as I mentioned. I was really actually more in the technology space. And it was through just patient experience that I ultimately decided that, we really needed to make a change in the system that we have today. And seeing some of the challenges that I was going through as a patient in the healthcare system, in between, figuring out how much I owed or how much I would have to pay for a healthcare service, to even being able to find and access great healthcare, great providers. And it was this experience that led me to start talking to friends and other colleagues about their experience as well. And I realized I was not alone. And in fact, practically every other woman that I talked to in the world was experiencing similar issues in terms of finding great healthcare. And so that's kind of when I started to join forces with my current co-founder, who is also a Cornellian, and we met at Cornell, and started to really explore what we could do to change the way that women's health in particular and primary care are conceptualized. And we have really started to do that through thinking, not just through the patient lens, but also the provider lens. And some of the other panelists have started to talk on the issues of, interoperability, of sharing data across the health system. All of these things are incredibly challenging. And they come down to basic or fundamental issues from our perspective in terms of how the technology system that supports healthcare delivery is set up. And the traditional way of thinking about clinical operations and clinical pathways, and how divorced that is from the technology systems that traditionally are supporting clinical care. So we at TIA have really reconceptualized the way that we want to approach building and delivering clinical care. And we have three kind of core pillars of our model. The first one is access, and there's two subcomponents of that: place, or wherever the care is delivered. And we'll obviously be spending a lot of time talking about that today, but also the economics of medicine. And so, I'm sure many of us on this call have heard, how are we shaping the cost curve in medicine, and how are we rethinking the ways that fee-for-service or value-based care is delivered. So that's a core fundamental pillar of the TIA model. In addition, we're very focused on preventive care. We talked a little bit about mental health services as element of healthcare and the really important ways that can change or shape a patient's long-term outcome. And we at TIA are very focused on saying, how might we deliver excellent preventive care that's pretty differentiated, and rethinking the care model that surrounds preventive care in general. And then the last one is collaboration. This is a pretty buzzy word right now as well in the healthcare space, saying how might there be patient and provider collaboration or shared decision-making tools. We believe deeply that in order to have the outcomes that we all are looking for and hoping to see in medicine, that collaboration, listening, respect for the patient and the provider are critical. And really saying how might we shape or change the experience that surrounds clinical care delivery so that we can have a collaborative model. With all those in mind, I kind of thought I might put together a short presentation to show how we at TIA are using technology to address some of those core focal areas. And Nancy and Charles actually asked me if I could show what we're doing. So I tried to put together a little mini presentation on some of the technology that we've actually built since COVID to support the iterative way that we're delivering care in this new world. And so just kind of to jump in here, when we started, when COVID hit, March 17th, our clinic in New York was completely shut down. Our revenue went to zero. We needed to figure out what we were going to do. And we took a quick step back, didn't have a lot of time, but really had to say, okay, what are we going to do? Because the bread and butter of our services are preventative, and they need to be, they're really traditionally not the types of services that you deliver via virtual care. So we really started to say, how do we rethink the models of virtual? So if you kind of go to the next slide here, we started to say, okay, how can we think about delivering preventive care consults online? That was the first and foremost thing we had to do. We had to figure out how we were going to get some of the quote guts of medicine accomplished through traditional, web-based forms and collection mechanisms. For example, doing eligibility checks online, very challenging to get a patient to complete that. How are we going to do that when we don't have a provider or an administrative person helping them through that process? But we also really wanted to rethink, what is the experience online, and is there an opportunity for us to deliver something that's truly unique, truly TIA, and helps really maintain that connection between the patient and the provider. So if you go to the next slide here, I have a little video of what our online booking experience looks like. And this just kind of gives us a sense for how we started to really rethink upgrading what the types of virtual visits are that patients could do between, and expanding the scope from something that's traditionally very low acuity focused to our high acuity or more consultative type visits. So the next slide. The next slide here shows a little bit about how we really focused on collecting the required information that's a patient needs to give when they're going through the onboarding process, or they're really saying, okay, I want to come in for an appointment. This has traditionally been where some of the virtual care platforms have fallen flat. And being able to use insurance on a virtual care platform is relatively unique in general. And then being able to actually get a high percentage of patients through this funnel and kind of completing the insurance and the payment information has been very challenging. So we had to figure out what is a great UX and how can we support patients through that, as well as saying, how do we leverage providers with as much information about what the patient is coming in for, in advance of actually seeing that patient in the virtual visit. And then lastly here, kind of showing how we really focused on keeping all of this in one platform. So, in a lot of virtual platforms that are providers are using today, the challenge has been that the collection mechanism for the health record is disconnected from the actual messaging with the patient and the provider facing tools for that patient communication. from the documentation service itself. So all these are different places that the provider team has to go to actually be able to engage with the patient. So our whole mission has been one platform for everything. The patients go to one place. They're not bumping out into Zoom when they want to talk to their provider. And the provider has all of the information in one location. So they're also not having to bump around into different locations to effectively deliver care, and they can focus on the patient.
Amazing
So
to see all the potential that's there. And it's a great thing that we see that everything's coming together. I'd like you to Sharam here, as we're talking about the nature really of healthcare being relationship based. And there's a lot of aspects of that relationship is how do you interact with the patient? What is the difference between an in-person relationship fostered versus this remote? So, and also the information about the relationship is the history of the relationship that we see with Tia, we see at VMDoc, bringing all that history together. We always talk about the charts and the medical record being very key. So Sharam, you're on the front lines here. This pandemic has come in, it's probably changed the way that you're interacting with your patients. Tell us about how the relationship has changed with telehealth pre-COVID pandemic and now. What have you seen as the big impact in a direct way? Not just, sort of the abstract, the theory, but now you're doing this on a daily basis.
Yeah, I mean, what's clear is that telehealth is here to stay. It was interesting before. Clearly, if we had a result, we could get on the phone and spend 20 minutes or 15 minutes talking to a patient and relaying to them what their issue was. And we were hesitant to do it because we didn't get paid for it. We couldn't time it right. We didn't necessarily get the patient. There was a lot of uncertainties. And so with this pandemic, I mean, telehealth has made an entry, and it's here. Patients love it, and I don't believe they're going to accept going back to the old ways. It's forced really all of the stakeholders that are involved in healthcare to modernize and provide patients with the opportunity to really connect. And some providers use Zoom, which has had its hiccups. We use VMDoc, which is intuitive, and you don't have to get on a second platform to do it, and they don't have to download anything and all that, which has made it easier. But it's really changed that dynamic, and for patients, it's nice because they don't have to drive to the office, sit in the waiting room, to have a 5-second or 5-minute face-to-face encounter. So my patients are super happy.
So it's really been really positive to see that gain in there. Has there been any hesitance? I'm actually curious, Jamie. One of the things that you're as a platform provider, and some of the questions that we came up with, they love the convenience, and we know that the convenience of technology is fantastic. But if you look at all the stories about convenience of banking, convenience of everything on the cloud, we have this issue about privacy and data protection. How are you addressing that? How is that being handled? And Sharam, maybe you can just chime in on there. Have your patients been worried about it, or is it a non-issue? I mean, but let's start with Jamie. How has that been something that you've had to prepare for?
Absolutely. Clearly here in the States, we have HIPAA, which is a guiding principle around patient privacy and what you do with patient health information. It's structured into everything that we do. Every client that we have, we sign business associates agreements with, which basically govern how we're going to manage that data. Every part of our technology platform has been oriented around how to protect information that's in it. We've actually structured parts of our platform to not hold any PHI, to make sure that that duty really fell to our hospital client as opposed to us, because they're already keeping that information in their patient record. So there's a lot
Jamie,
of that.
Whenever you bring a new acronym, can you just tell some of our participants who may not be knowing what PHI is or HIPAA?
PHI is Patient Health Information, and HIPAA is the Health Insurance Portability and Accountability Act, something of that nature. Health Information Portability and Accountability. So, it really helps govern a lot of the information and how it's and where it's supposed to be stored. The interesting thing is, if you take a look at cybersecurity breaches today, I mean, all of those entities have really been HIPAA compliant. And so if a hacker is going to get your information, they're going to get your information. The interesting thing is that a medical record is worth 10 times what a social security is worth on the black market these days. And so all telemedicine companies are very, very focused on what's happening, with this information and how to protect it.
That's fantastic. I know that Felicity, you mentioned the fact that you guys were really, when you started, you were an on-premise facility. You were looking at, and then the pandemic, like many things, came on. And one of the things that's really amazing is that we usually think is it's a technology kind of thing, but it's a lot of the regulation and everything that's gone on that enables it. For the longest time, you could not actually be reimbursed with the telehealth. Is that correct? I think there was a change at the beginning of the pandemic to do that. How did you handle all these changes with like technical support for your patients as they bring on these technologies? We heard about the hiccups of Zoom, plus the fact that you had to rewire your facilities to be there, and plus the fact that you deal with providers. How did you make sure that people got paid?
Yeah. I mean, there's a ton of operational changes and shifts that we had to be aware of. I think just to clarify one thing, prior to COVID, it was certainly possible to get reimbursed for virtual care services. It was just those services were typically reimbursed at a much lower rate relative to what an in-person service would be reimbursed at. So that was particularly de-appetizing to us in terms of saying, okay, how should we focus on launching virtual services? When COVID happened and they kind of changed a lot of the regulations around that, it opened up the doorway for TIA to say, okay, we can explore this as a pathway that we want to lean into. There's economic viability for us to deliver these services online. And what else was interesting is historically and kind of traditionally in virtual care companies, you'll see a lot of providers sitting off site from where you might have a clinical delivery location where those providers are, quote, less expensive. So you're kind of playing the economic market. Today, we're actually able to employ providers local to where our services are delivered. And that's helpful for us because we still have an interesting model where we're saying, part of the service collection that we want to deliver to our patients is focused to be online, and then part of it is actually still designed to be offline. So as you might imagine, doing 100% of women's care online is not possible. So we have kind of reconstructed how we actually think about a whole host of our services, most notably the Well Woman exam that contains, certain kind of physical exams that have to be done in order to get reimbursed for that. So we kind of say we have a half and half Well Woman at this point, where half of the services are delivered online and half of them are delivered offline.
Actually, that's a really, really good point. I know that during this pandemic, definitions of local have changed. I'm normally based in San Francisco. I'm now based in SoCal. In places such as New York, people are moving to New Jersey or to Connecticut. Curious, what is the impact? Do we have the regulations to allow people to do cross-border care between states? And, Sharam, if one of your patients is now, say, in Washington, Seattle, are you able to issue care through telehealth, or is that still a regulatory challenge?
I mean, I think our patients typically travel to other states, and we can continue to care for them. There's specific rules about practicing medicine without that state license. So you need local state licenses to be able to practice medicine in that state. So, a lot of telehealth providers will have doctors that have multiple state licenses, and practice, they may practice in Michigan, but they'll have state licenses for all of the West Coast and see patients that way. But you have to have a local license to do it.
And that was actually relaxed to a certain degree during COVID, where doctors were approved to practice across state lines. Everyone right now is wondering whether that's something that's going to stick or not stick. And in fact, there's the Federal Medical Licensing Compact, which has been in place where a lot of states teamed up together so they could cross-license doctors. But states, as a state right, are really fighting for what Sharam is talking about, which is being licensed in that given state. Clearly, giving up the revenue model is a key driver of what that is. And it kind of speaks to a little bit about what might be wrong with healthcare that needs to get fixed and some of the friction points that exist out there that could be streamlined.
Sounds really good. Christine, one of the things I wanted to get a sense is because you're dealing in a payer system, which is very different. A lot of things are not going through traditional health insurance, but either direct pay or through the employer. And as we know, employees are now everywhere. How's the pandemic changed? Are you seeing a greater uptick because of the migration everywhere? And has that changed in how your providers are getting reimbursed?
Yeah, it's a great question. So a couple things. Part of our services, so therapy and psychiatry, are clinical services, and they can be reimbursed under, you know, I think it's like 6 CPT codes that we have that we can bill for there, and that hasn't changed for us with the pandemic. That's been the way it's been. We do serve employers and payers that are national in scope, and so we have, as a result, therapists and psychiatrists that are licensed across all 50 states. So for us in particular, it hasn't changed it very specifically, mostly because we were already operating within the model of needing to be live across all 50 states. And in some cases, at least with coaching, that does not, by the way, require a state-by-state license. We can actually do that internationally in 30 countries across the world as well. So that hasn't changed for us specifically. It does, however, maybe change how we service our supply demand model. So I sort of referenced before, a lot of what we do actually on the back end is ensure that we're getting people to the right person at the right time, and very specifically somebody who has capacity to be able to handle them. And we've seen our demand spike, you know, for coaching about 150%. Same time last year. I think these are August stats, and then about 3x for therapy and psychiatry. So more of our focus is really more on scaling and less around licensing and cross-licensing, because we had covered that pre-pandemic.
That's fantastic. It's amazing. I mean, obviously it makes a lot of sense that there's such a huge uptake. When you look and coordinate, you're talking about, especially with psychiatry services, how do you coordinate now when your patients have moved about for such things as, like, say, medications? Is that done with their clinician? Do they have to repair up? How does that handle it? Because it is one of the things I think that's about healthcare is that there's so many people involved to bring a care to an individual. And I think BMDoc, and if you look at TIA, what they're trying to do is bring everything together. How are you handling that? Since often that you, in addition to the remote care, where telehealth is a natural for the mental health space, how do you handle it when you have to go back to the physical space for mental health?
Yeah, I think it's such a great question. So a couple of things. Our psychiatrists that we have on staff do help people with medication management very specifically, and generally that's in the category of SSRIs and similar. And so we work back with the, you know, I think, and this has come up a couple of times on this call today, interoperability in all its forms is really important. And we, to be successful in serving our members, have to be able to work within the system. And so it does require us to be able to enable our members to be able to go to their local pharmacy and fulfill the script. There is a universe where we could possibly help fill the scripts by mail order for them in certain areas. But today we do have to work within the current system to do that. And you know, and to be honest, I think in particular within mental health, there is a therapeutic alliance that you've built with, if you have an existing therapist or a psychiatrist and you're operating under the care, we don't want to break that, right? So as much as we can do to be able to operate within the confines of what makes the member comfortable and where we can be additive to something that they already have, we will certainly do that.
That's fantastic. I think one of the things that you talked about is how do you allocate the load, as you mentioned. And I'm actually really curious. I don't know how many Zoom meetings people have had today. I mean, we're at 4 p.m. I think some of us have been staring at the screen all the time. And while it's really convenient that we don't have to drive everywhere, often it means that we can go from one meeting to another or one patient to another. Has there been any downside from telehealth? Is there any Zoom fatigue or whatever the technology platform for providers that you're seeing through either your customers on Cloudbreak, through TIA, through Ginger, and yourself as a practicing physician, Sharam? I'll start with you as the doctor, Sharam.
Yeah, I mean, I think Zoom fatigue is for sure real. I mean, we've changed the way I practice medicine in the sense that I had support staff from, you know, an MA gathering information to a nurse collecting vitals and data to a scribe, you know, collecting and putting in all the information in the EHR, to now myself and the patient. And then I have to gather information, try to get vitals that they're getting at home. And so it's put a lot of onus on me to kind of tidy up those ends that I didn't have to deal with before. So that's increased the work. And then you're literally going from one call to another call to another call. So there's really not a lot of time for chit chat and, you know, the breaks. Like before, you would go from one patient room to another and maybe you get a sip of coffee and grab something, and, you know, you have a second of a break while the nurse gets a vital. Now that doesn't exist anymore. So, you know, there's definitely a lot of fatigue that goes with it.
How about you, Felicity? Are you seeing anything from your provider network about things that they're asking for? Are you like having automated scheduled breaks so they have a coffee break when they're providing? Is there anything that's coming out? And I'm going to throw that same question to you, Jamie, afterwards, so you can hand it off after when you're done, Felicity.
Yeah, of course. So I think what has been interesting is when we first started delivering care online, there was a lot of kind of cold flu, COVID scare stuff that we were dealing with. And the way that I would describe that is a lot of short back-to-back appointments. Over time, since then, we've built out a mind share with our patients on what we can fully deliver. But when we were doing those short back-to-back appointments, our providers were very screaming, or like, we need more documentation time, we need break time, etc. And I think just to kind of reiterate a couple of things that I've said already that have come to play here are, one, figuring out how we can collect the data for, the review of systems, for example, in advance of the patient actually showing up in the provider room. Has been incredibly helpful. So there's less data collection, and kind of what Sharam's referring to with tasks the MA would do, we're trying to do those virtually in advance via our technology platform. And that's been very helpful for the providers. They love that. And then the second thing is, our providers are splitting their time, and they're very thankful for that. So they're doing half virtual, half in real life, and that's giving them a break from the screen. And it's interesting because when we started to say, oh, we're gonna actually revert you back and do 100% in real life care again, they were kind of like bummed about it, and they wanted to do half virtual, half in real life. So it's interesting. I think a lot of us saw when COVID first started happening, providers were very excited about the virtual opportunity. It was a challenge for many of them to be comfortable with the technology, but also excited about seeing their patients in their native environment and being able to kind of deliver care in a new form factor that they'd never tried before.
How about you, Jamie? How are you seeing your customers and your partners dealing with this new form of care delivery?
Well, let's keep in mind that pre-telemedicine, right, physician burnout was a real thing and still remains a real thing today. Physician burnout, I mean, you take a look at clinical teams across the country, and physicians are one of the #1 most burnt out workforces in the country as it stands today. And that was a problem that we as a company were directly trying to solve. There are a lot of companies out there who talk about being patient-centric. We actually very purposely talk about being provider-centric, partially because that's where I cut my teeth. Before this, I ran an ER hospitalist and anesthesia group, and I saw that the issues that all these providers were having on the front lines of care. And so our goal as a business was to put tools at their fingertips that didn't intermediate their relationship with the patient. If you take a look at something like an electronic medical record, well, what happens? Instead of looking at you, I'm documenting in the record, and I'm not really developing the rapport that I need with the patient. I'm not making eye contact. I'm not doing all those things that we call as webside manner instead of bedside manner now, that I should be doing to really connect with the patient. And by the way, this communication is like the #1 diagnostic tool that a patient has. If you look at any patient chart, history of present illness, family history, all those things are communication-driven parts of the chart that really provide a context around the patient. And so as we're trying to address this physician burnout, it's about, okay, well, telemedicine isn't just video, it's email, it's chat, it's really any digital health tool that changes the place-space relationship that we normally have with the healthcare system. If we take a look at healthcare, like the whole infrastructure has been designed around this in-person visit, from regulatory to how we pay, from a fee-for-service standpoint, it's all built around that. And I think a lot of the friction that's happened as of late, especially on the provider side, is I know telemedicine can help improve my work environment. If I take a look at closed-end healthcare systems like Kaiser or the VA, they do north of 50% of their visits over telemedicine. And so it really shows you what the potential of it is that still hasn't been replicated in broader community environments. So doctors, I think, are finding a lot of friction with, I know this is the right thing for me to do, but how do I get paid for it? Because right now I need to make a living, and that's still a little vague and a little unclear, even though there's been a lot of work to develop chronic care management codes and all these different types of CPT codes so people get reimbursed. There's still a little bit of friction there, but I think largely what's happened during COVID is patients and doctors built a ton of muscle memory with the fact that this can be efficient, more cost effective, can help, save a ton of travel time for the patient. If you're a patient and you have to go sit in a waiting room and pay for parking and do all these things that you now have to do when you go to the doctor's office, but instead you can take that call from home, that's a huge advantage, and you are going to have a much more satisfying experience, and the provider's going to have a lot less anxiety because he doesn't have to deal with an angry patient who sat in his waiting room for 30 minutes than was available prior. So this is really about, telemedicine's not there to replace in-person care. It is there to augment it. It's there to eventually end up with an in-person visit at the end of the day. It's just another tool in what is the doctor's now digital medical bag to help them better manage their own life. And if you take a look at even things like asynchronous telemedicine, you don't have to necessarily, if you're a dermatologist, you can wait till the end of your shift to go through and take a look at all the moles that people might have sent you to say, hey, how does this look? Asynchronous telemed time shifts care the same way a DVR time shifts watching TV. So we're still a learning curve that's happening, as Sharam said, right? Like people are still like these back-to-back video visits can be taxing, but the whole goal is to learn from that and then streamline it and really create a better stakeholder experience, not just for the patient, but for the provider as well.
That's a really good point. I'm gonna ask Christine here, because one of the things I know that that Ginger's able to do is to bring a new modality for care with your therapist through his text. One of the things I'm really curious about is how does that work with the provider? Because I know that when I'm texting, I get accused, especially by my wife, that I missed a text. So it's not like one after another synchronously, it's actually asynchronously. So I might text, and then 10 minutes later, and then 30 minutes later, I'll have a text back and forth. How does that impact if your providers are dealing with so many patients? And how do you bill for that? Do you bill, is every text a billable event?
Yeah.
Speak about that challenge, about the fact that we're not quite synchronous anymore. We're not quite asynchronous.
Yeah, such a good question. So to clarify, so our therapists and psychiatrists do see people over video, and those are session-based, on the cadence at which they determine that is appropriate for the member. So 45-minute to 60-minute appointments. Coaching, which the majority of, every single Ginger member starts with a coach, and the coach is longitudinal through the relationship, whether you add a therapist or psychiatrist onto your team or not. But coaching is what happens through text, and that is all synchronous. It is all real time. So if you think about kind of how this works on the back end, a coach who, by the way, is trained to essentially be emotive and to draw emotion out from people that they've never met before over text, which just, as you mentioned, right, so much can be misconstrued. There's a really highly trainable skill set there that they have to really master to be a Ginger coach. They may be handling multiple conversations at a time. Now you throw on top of this a pandemic. So you have people coming in who, there's COVID, natural disasters, racial injustice, elections, on top of everything else that we were seeing pre-COVID, work-life balance, parenting, relationship challenges, trouble with your boss. And so the intensity, and we actually measure intensity through our system, the intensity of those conversations have increased dramatically. And then they themselves, right, they're people, they eat, they sleep, they have kids. 30% of our coaches are Black. Right, so they are dealing with a lot of, I think, the trauma and the triggering that comes with a lot of what's happening today. Many of them are parents, so they are coaching multiple people at a time over text while their children are at home and are going through school. And many, are in situations where those who, close to them have been affected by COVID. All this to say, there are a number of mechanisms, both in sort of how we work with them as employees of the company, and then technologically how we support them, especially during this time. So one, we have stipends, additional flexibility that they have. We've actually hired a coach, a full-time coach, to be able to help coach them during this time. And then from a technology standpoint, this is where I think it gets really interesting. After every session, one of the things that we do, we actually measure the sentiment of the coach after their shift. Right? How were you feeling? Were you feeling overloaded? Were you feeling great? And we look at that over time. And the reality of it is, because our system is the one that allocates where a member goes, we are not going to hand you somebody new if you are already into really intense conversations that you may not be able to effectively handle. So it's better for the member. It's better for our coach. So, things like that we can do within the system to really manage, part of managing the mental health of our own coaches is to manage the supply and demand imbalance for them too. And so we've done a significant amount of work on that back end to make sure that they're feeling supported from that perspective.
Well, that's fantastic. I think it's, really the notion of cares. We often think, and one of the things that we sort of presumed during this panel discussion is talking about what telehealth is. And we talked about really the delivery of an in-person with an expert to provide that information. But it's been alluded to many times in the answers about the ongoing relationship. A lot of healthcare today in the US is about chronic conditions and getting vital signs, getting, what's known in the lingo as RPM, or remote patient monitoring, where it's not really the interaction, but you're providing information constantly to the healthcare team about their vitals. What is the role of RPM and this all this information that can be collected in how it impacts telehealth? I mean, is it going to be the sense where you get these see these Apple Watch ads where you've got an arrhythmia, and then also you get a notification, schedule a meeting with your cardiologist or something? What is happening with this technology to extend the time and space of what a healthcare engagement is? Does anyone want to start with an answer on that based on their experience?
So, from a mental health perspective, and mental health, I think, is notorious for not really measuring health outcomes on a regular basis, right? There's not a test. There's not like a blood pressure test in the same way that there is, right, for depression. So there are a number of sort of like, I'll call it clinically validated assessments that are actually not used very regularly within clinical practice at all. You sort of assume that you go to a therapist, and you go to a therapist until you don't go to a therapist anymore, right? You try to resolve an issue, but there's really no sort of like beginning or end to it other than that you go. And that's something that we specifically look to upend in our model, where we actually deliver those assessments out to our members on a regular basis for which is called the PHQ-9 for depression and the GAD-7 for anxiety. And we actually look at those over time. Right. So if somebody is showing a spike in sort of how they're scoring there, we can actually alert their provider to make sure, right, if they've checked in on an off day, that person is feeling off and they might want to be able to reach out. So mental health, I would say, probably very early in terms of, I'll call it its maturity in capturing data in any meaningful way. And so we've started there and are starting to catch a lot of those signals, I think, along the way. A second one, I think, that is just, to note, because most of our interactions happen over chat, we have a set of technology that's been developed through our data science team that can actually help support our members by flagging people who might be at risk of self-harm or suicidal intent, right? So that's not just somebody in a conversation saying, I am going to hurt myself. It is over time, a combination of assessments, what's coming up in chat data, notes from a coach, taking all of that over time together to be able to effectively be able to go back to the provider team and say, hey, this person might need an outreach, and provide them with some peace of mind of the quality of what we're providing and reaching out at the right time. So a little bit different within mental health perhaps than it is in the physical health world, but certainly an example of how we've done it.
A lot of healthcare is about prevention. I'm really curious, Felicity, with Tia, are you doing anything preventive with remote monitoring? Are there, in addition to the app, are you sending your members with any devices and having the information feed in? Or how are you looking at remote monitoring for preventative health?
Yeah, it's a great question. And I love that Christine touched on clinically validated mechanisms for remote monitoring, because that actually is the challenge at this moment in time. And there's a huge opportunity between Apple Health data, Fitbit data, et cetera, to be able to integrate that into provider workflow. The question for providers is constantly, how do I even make use of this data? And that's actually, not to go back, but that is really where Tia started. Back in the day, we have built a patient tracking app where women can track a whole host of symptoms. And that data is flowed into our providers, and our providers are trained on how to use that data in a diagnostic way when a patient comes into an appointment, which is really cool and differentiated. And we kind of started doing that because we noticed the trend of women using cycle trackers out there over 50% of women do use a cycle tracker, and that data goes nowhere valuable from a clinical perspective. That being said, it is not, validated clinically in the ways that these questionnaires that Christine has mentioned are. And I think where I stand with respect to things like being able to send out pulse ox devices to patients, or even, as we're entering the pregnancy space, we get a lot of questions around fetal monitoring devices. The question I have for the developing virtual care environment is who's going to pay for that, and really questioning, or looking to the payers to say, is there some sort of way that the preventive care codes can actually help to support patients in fronting the cost for that? I mean, obviously, as we think about value-based care and the economic models there, it's a much more kind of feasible or tenable concept. But as we kind of move down the road with virtual care and wondering how we can, triage a lot of these concerns at home, I think in order to see a broad-based expansion of RPM devices, we'll need to understand the payment models for those things.
Actually, that's a great question, because a lot of the questions that, the attendees are asking about is really, and I'm going to sort of go into this before we look at the future, is how do people look at the business? COVID has been a great catalyst to do this. Do you see that this is going to be a space that is going to grow considerably there? Are you going to get the regulatory support? What are the things to enable this to be a viable segment of the healthcare industry? I mean, what do are you, obviously we're all optimistic because we are involved in entities that are working in this, but do we see more accelerated growth out of this? Is it continuing on this path? What are some of the things that are out there to see post-COVID to support the future for telehealth? Jamie, why don't you talk about since you have a broad view touching so many, do you see the regulatory support coming? Because we know that payments is a big issue. Not all the codes are there. And everything in healthcare, you may have heard the acronym CPT. It's one of those things, it's like when you go to a restaurant and say, oh, there's no button for that, I can't charge you on that. If there's no code, no one knows what to do.
Yeah, I mean, to Felicity's point, as we move to more of a value-based world and move away from fee-for-service, which, by the way, has been a huge struggle, because that everyone's really kind of, when you're trying to come up with what the right value-based model is that per member per month? Should we be paying for outcomes? There's so many different factors that come to play, and each of them, while on the face might seem really good, they end up with these weird externalities that happen afterwards where you're like, oh, we thought that was a good idea, but then providers started behaving in this way, and that's not good. So it's going to take a little while for that transition to really happen. And so, as we go through the machinations of figuring that out, it's a struggle. I happen to think that, I saw a comment in the questions around the fact that telemedicine and was being paid in line with in-person visits. Well, is that or is that not the right thing to do? There's most hospital bills, there's a professional component to the fee and there's a technical component. Well, I could see a lot of rationale to keep that professional component the same, because the professional component of that hospital bill is really paying for that physician's smarts, ability to diagnose, and ability to guide care and treat the patient. But the technical component, it's clearly less expensive to treat someone over telemedicine than it is to maintain bricks and mortar for that same visit, right? So as time goes on, I think there's going to be a lot of work, and there's a ton of focus now with figuring out what it is. But really, people don't say, again, I'll go back to my stethoscope thing. Doctors have stethoscopes and no one's saying, how do I get reimbursed for using that stethoscope? You have the stethoscope because it allows you to listen to the heart and do things that you need to do as a clinician to make a diagnosis. The same is true of these digital healthcare tools. And we should be treating them in a very similar fashion. We shouldn't be looking to reimburse for digital health. We should be looking to reimburse for healthcare, and however the digital tools are deployed should be accepted.
That sounds great. Sharam, you're very tech forward. You're looking at this. I'm curious to see from the trenches what other physicians are looking at. Can you sort of speak about, the culture and how the adoption, are your colleagues saying, wow, this is amazing, we cannot wait? Or is it still show me? Tell me about how, because we can have all the technology, but we still need the physicians to provide it using those technologies. What do you see happening there?
I mean, I think it's a good point, because it's really cool that a patient has a blood glucose, blood pressure, heart rate, oxygen monitoring, weight monitoring, temperature monitoring device, and they come in with 300 pages of their blood sugar over the past 2 months. But realistically, most physicians aren't going to sit down and go through all of them. They can't. They're limited by time, et cetera. So I think what COVID has done and this jump into telemedicine has done is it's allowed us to push technology. And as technology gets better in interpreting this information, right? Taking all the information, putting it together and coming up with realistic recommendations, or even recommendations based on what we do. So if I see a blood sugar that's a certain number, I react by doing X. And so every time that blood sugar number comes to this certain number, the new tech device is going to tell me, you usually do X, would you like to do X? So now we're not relying on these clinically validated recommendations, but what we're doing is we're using our own technology to say, hey, this is what you've done in the past. Is this what you'd like to do again? And so therefore you allow these physicians to take all this technical information and have really some sort of tangible outcome from it. And you bypass a lot of the regulatory hurdles because it's stuff that they were doing originally. So I really think that there's an opportunity here, but there's going to be a lot of resistance. I mean, I see it now in my partners. Not everybody loves to use technology.
That's one of the things that's really interesting is as we look at the technology, we've really talked about those things which are about knowledge. We've talked about like the expertise. These things are really easy to do over remote through a video. I'm curious, are you aware of anyone who's doing anything in the more hands-on kind of healthcare remotely, like either sending devices out to do either things like dentistry or physical therapy or occupational therapy? Is everything being done in a telehealth for those kind of things that are traditionally more hands-on? Anyone aware of anything?
I know that in the musculoskeletal space, so specifically for physical therapy, there's a lot of, I'll call it venture capital investment in companies that have recently just sort of like sprung up over the last, so Hinge Health, I think, is one of them. The rest are escaping me. There are a lot of them now. And it's because it's and I hate to say this, it's lucrative, right? There is a lot of opportunity to make a difference there, and to be able to, again, deal with a dwindling, I would call it, supply of expert resources there, and have people to be able to do that from the home. So I think they do supply some type of device that can kind of look at your positioning and help you to do the things that you need to do. So one that
a lot of that is actually available via AI now. They can actually look at the inflection of your knee, see what angle it is, and there are a lot of apps that are now using machine learning in order to work through not only rehab post-surgery, but prehab, pre-surgery, getting people in shape prior to having their surgeries to give them the best outcome afterwards. So there's a lot of work being done in that space. And look, there's thousands of different telemedicine use cases, right? I mean, we're talking about when could you insert video into a care protocol? When could you insert email? Or, I mean, there's literally thousands and thousands of different use cases that are out there.
One of the really cool things that I think, Intermountain is doing this, they've been doing it for a while, but they're basically calling in specialists in other locations to remote, specifically ER facilities, to help typically lower credentialed providers perform a service, which is really, really, really cool. And probably one of the most fascinating ways of extending a specialist care model that I've ever heard of. And I think that that's happening at higher rates now that there's obviously shelter in place protocols.
That's fantastic. I think that's one of the things. The challenge is how do you extend access? I think we change space, we change place, and we change time to do this. I'm going to close with 2 questions, but the first one is sort of more to help our attendees. Are there any tools or devices or website resources in addition beyond your products that you would recommend that you see people look at? Like, are people, the benefit of connected pulse oximeters? We saw that with the new Apple Watch 6. Is there anything that you're seeing and saying, wow, this is a really great thing that will help you manage your care that you're seeing out there that you might point people to, and it could be resources? Curious, like how many people on the panel have Apple Watches? I'm curious.
I mean, I've got
Oh,
a
one.
Whoop, got my Whoop, my Aura Ring. I'm testing them out right now.
I'm a former Fitbit executive, so I'm biased.
Well, that's
Highly recommend
fantastic.
it.
Yeah, I think to Felicity's point before, like there's now a fair amount of research coming out on telemedicine and a fair number of papers that are being published on how to effectively use, remote patient monitoring for chronic care management. And, there's journals and conferences and the American Telemedicine Association and a ton of resources for people that have questions to go out there. We moderate a tweet chat now every other week at the hashtag #TeleMedNow, which has a bunch of great information that's been buried in it, with actual practical tips on how to implement a telemedicine program. So I think there's a ton of resources out there, maybe too many, in fact, as you get a different level and quality of information from various sources. It's kind of like big data. To Sharam's point, it's like there's so much data out there, your eyes might glaze over, and really what needs to happen is people need to make it useful and actionable, just like RPM data. So there's a ton of different things out there.
Well, fantastic. Well, I'm going to close with this. We're going to get our crystal balls out. We're going to look and gaze to the future. We have a vaccine. Everything is coming back to normal. We're going to see each other. This will be done an in-person event someday. So now we're back to some semblance of normalcy. So 2 questions. 2 years from now and 5 years from now, will telehealth be the primary way that we get healthcare? Will patients go back to saying, I really like the personal relationship, and that'll become the primary, or it's going to be a mix between the two? Why don't we start? Christine, how do you see, the 2-year and 5-year horizon? Is this just a temporary blip and then it goes in normal, or we're completely in a new world?
Yeah, so I'll give the mental health perspective, but I think we are slowly going to move towards a virtual first world on this, knowing, by the way, that not everyone is appropriate to be treated virtually, right? There are just some things that have to be done in person, but having that virtual front door for mental health, I heard someone say this once and I thought it was, it's sort of a shock that we didn't start with mental health first when it came to telehealth, because it is really that either face-to-face conversation or sort of remote conversation, and not as much of the physical piece of it, although there's certainly elements of reading someone there. So my prediction there, and obviously I'm very bullish here, is that mental health will move towards a virtual first model. We're seeing a lot of uptake on our end of people who are just, again, sort of surprised at how easy it is, and may not be able to imagine having those, I'll call it base case interactions anywhere except on their smartphone.
Fantastic. Sharam, you're coming in and, 2 years or 5 years, are all your people in the practice going to be 5 years, going to be doing everything from the beach? How do you see the 2-year and 5-year horizon for telehealth among your patients?
Well, I'm a surgeon, so I wish I could do it at the beach, but ultimately I still have to cut and paste. But I think that, the telehealth is here to stay. I mean, I think for a consultation, for a follow-up, for remote monitoring, there's a lot of different interactions that we have with patients that don't require touching, essentially. And I think there's a lot of really good technology that we can use to monitor patients remotely, to be able to connect with them without the inconvenience of them being exposed to whatever is exposed in our offices. And so that's going to stay. I mean, ultimately, we're still going to have to operate on people, do ultrasounds, do exams, do specimen collection, whatever it is. But from the personal aspect, it's here to stay.
How about you, Jamie?
There's a lot of sayings that people use. Cat's out of the bag, toothpaste is out of the tube. Pick your saying when it comes to that. But we've already seen a little bit of backtracking as the healthcare system has opened up, with doctors again stressing the in-person visit. I think patients are going to start voting with their fingers instead of their feet, and they're going to want to make sure that, like, if you're a health system that doesn't have a digital first strategy in place, I think in the long run you're going to be suffering, because it's about access. It's, if you can save the patient again from driving, parking, doing all these things, it's just good patient relationship management to have a digital front door. I think that one of the things that has to change, if you take a look at all the doctors that are out there, they weren't trained like this. they weren't trained to do a physical exam remotely. And that's the type of thing that new doctors coming out will, and it's going to be much more communication driven. Do I need to put hands on body, or can I tell the patient, put pressure here, how does that feel? Describe, it's a different type of physical exam. And so I think as we get more and more doctors, and telemedicine is now going to be ingrained in, medical school curriculums and things of that nature, we will start to move more and more quickly in that direction. But I think getting existing people to change their behavior, again, I think that's the broader challenge in our healthcare system today. We don't have a technology issue. It's really not a tough technology to get a patient record from one place to the other. Yet why do patients still find it so challenging to do? Because hospitals and doctors weren't built that way. And so there's a lot of infrastructure change that needs to happen, but I definitely think digital front door is the way things are going.
And Felicity, you get the final crystal ball. What do you see in 2 and 5 years?
Yeah, I agree with everyone else here saying I think that virtual care is here to stay. I think my perspective is a little bit nuanced or differentiated in the sense that I think the focus in the next 5 years in the healthcare world is going to be on making preventive care and primary care an effective model, and knowing that we have a huge economic issue in that space, looking at different ways that we can leverage technology and virtual care to deliver those necessary services is going to be top of the list. I also think, as Christine has shown us with her discussion on how coaching can be so effective, coaching and these consistent kind of touch points and figuring out how to make care more of an everyday journey versus this once a year occasion that happens with patients is going to become much more the norm. And in order to do that, we have to meet patients where they are.
That's fantastic. Well, I'm looking at all the questions, and we could be here for another couple hours, but unfortunately our time is done. I'd like to thank our distinguished panel. Thank you so much for making time to share your insights and your experience. This is something that's very much part of our daily lives now, whether we wanted to or not. So knowing what tools are available, what services are there to be able to take care of our health, which is really important, especially in this time. So thank you very much. I don't know, it's been a long time since I've used a Zoom, but if you can, put a clap or something in the chats for our wonderful panelists, that would be great. Tomorrow, you'll be receiving a brief survey. If you can give us the feedback to what could be better and what you liked, it will really help us as we plan for more and more programs. I'm sure you're getting lots of emails. Be sure to sign up for other events that are coming in on a whole range of topics. So it's really important to get that out there. So I'd also like to thank the West Coast team of Alumni Affairs for putting all this together and bringing us together. A lot of work went behind the scenes on this. So with that, that concludes our program. Please stay healthy. Please stay safe.